Getting an inguinal hernia repaired is one of the most common surgeries out there. And for millions of people, it's a pretty routine fix. But what happens when the thing that's supposed to fix you actually creates a whole new chronic problem? Well, for a small but really significant number of patients, the story doesn't just end with a nice, clean recovery.
I mean, just imagine this for a second. You go in for a totally routine surgery, you expect to be back on your feet in no time, but instead you're left with this nagging, persistent pain that, well, it just won't go away. And look, this isn't some rare, hypothetical thing. This is a tough reality for hundreds of thousands of people every single year.
So this condition actually has a clinical name. It's called chronic post-herniorrhaphy inguinal pain, or CPIP for short. And what it means is basically any pain or discomfort that sticks around for more than 3 months after the surgery. And we're not just talking about the normal aches and pains of healing here. This is a real signal that something else has gone wrong.
Okay, so 2 to 5%. At first glance, that might not sound like a lot, right? But think about this. There are over 20 million hernia repairs done around the world every year. So that small percentage, it actually translates to hundreds of thousands of people. People left with this life-altering pain from a problem that was supposed to be fixed. So the big question is, why? Why does this even happen? How can a surgery that's meant to fix something end up creating a whole new painful problem? Well, the answer is all tangled up in the complex anatomy of the groin. And wow, this image really shows you the heart of the problem. See, the area where the surgeon has to work, the inguinal region, it's like a crazy busy highway interchange for a bunch of really important nerves. You've got the ilioinguinal, the iliohypogastric, and the genitofemoral nerves all crisscrossing right through this tiny surgical area. It is super crowded in there, and the surgery is happening smack dab in the middle of this really delicate network. So during the actual repair, all sorts of things can happen to these delicate little nerves. I mean, they can get accidentally cut, or stretched, or even just bruised. Sometimes a nerve can get caught up or entrapped by the sutures or the little tacks that are used to hold the surgical mesh in place. And get this, even the mesh itself, or the scar tissue that forms around it, can end up pressing on a nerve and causing inflammation, long after the surgery is over. And the result of all that irritation is a very specific type of pain. It's called neuropathic pain. And this is not the same as the dull ache you feel while an incision is healing. No, we're talking about spontaneous, often burning pain, and this extreme sensitivity where even a light touch can be agonizing. It's basically the nerve itself just misfiring, sending these constant, totally wrong pain signals up to the brain. Okay. So if we know it's nerve pain, you'd think pinpointing which exact nerve is causing all the trouble would be pretty straightforward, right? Well, not so fast. That actually brings us to the next huge challenge in treating this condition, the big diagnostic puzzle.
This really is the key question that clinicians face. We've got our short list of suspects, right? Those 3 main nerves we just looked at. But figuring out which one is the actual culprit, well, it's surprisingly tricky. And here's why. This slide right here shows you exactly why it's so tough. So on the left, you see the typical pain pattern if the ilioinguinal nerve is the problem. On the right, you've got the genitofemoral nerve. Take a look. Notice anything? Yeah, they're practically identical. A patient can't just say, hey doc, it hurts right here, and have that be the answer. Because where they feel the pain, the sensory territories of these nerves, they overlap. The signals are all getting crossed.
So to solve this puzzle, pain specialists have to pull out a whole diagnostic toolkit. It's like a detective's process. First, it starts with a really careful physical exam, poking around, looking for very specific tender spots. Then they'll use imaging, things like ultrasound and MRI, to rule out other stuff, like maybe the hernia came back. And then, and this part is absolutely crucial, they turn to something called diagnostic nerve blocks. And this flowchart from the research really lays out that whole journey perfectly. You can see it right there. After the initial exams and trying some basic stuff, the huge, pivotal step is that diagnostic block. What happens is a doctor uses an ultrasound to guide a tiny needle and inject a local anesthetic right next to one of those suspect nerves. And if the pain just vanishes, even if it's just for a little while, then boom, they found their culprit. This is the absolute key that unlocks the door to finding the right treatment. Okay, so once they've identified the right nerve, what's next? What can actually be done about it? And this is where we get to the really hopeful part of this whole story. See, the modern way to treat this isn't just taking a shot in the dark. It's a really logical progression. You can think of it like climbing a ladder, step by step, towards relief.
So the first step, the bottom rung of that ladder, is always going to be the most conservative approach. We're talking about things like topical treatments, lidocaine patches, capsaicin cream, or oral meds that are specifically for nerve pain, like gabapentin. Also physical therapy and just, learning to modify your lifestyle to avoid things that trigger the pain. And for a lot of patients, this is actually enough. It helps them manage the symptoms really effectively. But what happens when that stuff isn't enough? When the pain is just too much? Well, for those folks with more severe pain, it's time to climb a little higher up that ladder to more direct, more targeted interventions.
So the big review we're looking at here groups these interventions into three main buckets. First up, you've got nerve blocks and a technique called pulsed radio frequency, or PRF. That's where they use these little energy waves to basically tell the irritated nerve to calm down. Second, there's neurostimulation or ablation. This uses either electricity, heat, or cold to disrupt the pain signals. And finally, the third option, neurectomy. That's where they surgically go in and remove the damaged part of the nerve. And for a long time, that last one was kind of the go-to for the really tough cases.
Okay, get ready because this slide is really the heart of the whole thing. And the numbers, they are pretty startling. Look at this. For nerve blocks and that PRF technique, a staggering 98.1% of patients got relief. For stimulation and ablation, it's almost 93%. Now, look over at neurectomy, the most invasive option of all. Now, it's really important to see that little note, that 24.7% is for complete relief, but even so, the contrast is just, wow, it's dramatic. The data here is painting a very, very clear picture. So this really powerful new evidence has led to a major shift, a whole new way that doctors are now advised to approach this kind of pain. It's not just about trying random things anymore. Now, it's about following a new evidence-based roadmap for treatment. And here it is. This is the modern pathway to getting relief. You can see that after that first line of conservative care doesn't work, the algorithm points clinicians directly towards those interventional techniques we just saw, the nerve blocks, the pulse radio frequency, the ablation. And surgical neurectomy, it's now way down at the bottom as a last resort. It's only for the very, very few cases that don't respond to these other treatments that are way less invasive and, as we saw, way more effective.
And the authors of the review, they summed it up perfectly. They said, and I quote, "Minimally invasive techniques show promising results and should be prioritized before clinicians resort to such surgical interventions as neurectomy." I mean, that's a really powerful conclusion, and it's driven directly by all that data we just looked at.
So, what's the big takeaway here? The most important thing to remember is that the script has totally been flipped on how we treat this kind of chronic pain. We now have an evidence-based pathway that puts these less invasive but highly effective treatments first. And what that means for patients is a much, much better chance for real pain relief and getting it sooner.
And that really leaves us with one last thought. For anyone who's actually facing this kind of chronic pain, just understanding this new approach is incredibly empowering. So we'll leave you with this question. Could knowing the right things to ask your doctor, questions about nerve blocks, about radio frequency, about this whole treatment ladder, could that be the key that changes your entire outcome? Because that's exactly what all this new evidence seems to be telling us.